Good afternoon. My name is Giancarlo Suffredini. I'm going to be speaking to you about silent liver disease and its impact on outcomes following coronary artery bypass grafting surgery. In addition, I'll review background information on the prevalence of silent liver disease, its most common cause, how it's detected, and interventions that may help to improve outcomes. I don't have any relevant disclosures. Silent liver disease describes the asymptomatic, pre-cirrhotic stages of chronic liver disease. The most common cause of chronic liver disease is metabolic dysfunction-associated steatotic liver disease, or MASLD, which currently accounts for 60% of prevalent cases. Advances in screening tests over the past 2 decades have made the non-invasive screening and testing for compensated chronic advanced liver disease possible, and the results are impressive. In the general population, between 5 and 7% are affected, and the overwhelming majority are unaware that they're affected. On the right side of this slide is a figure from a recent New England Journal of Medicine review. This figure demonstrates how non-invasive testing has enabled the early detection of advanced liver disease in lieu of invasive liver biopsy. The FIB-4 is a score based on a ratio of age, platelets, AST, and ALT. Low scores effectively rule out the presence of significant liver disease. Intermediate scores require second-line tests such as elastography, which measures liver stiffness, to support the presence of advanced liver disease, and elevated scores are highly suggestive of the presence of advanced liver disease. The ELF score measures 3 specific proteins to generate a score related to the presence of advanced fibrosis. Liver stiffness measurements can be obtained via magnetic resonance or ultrasound. Ultrasound-based measurements of liver stiffness are common, with VCTE, which stands for Vibration-Controlled Transient Elastography, being the most common. Elastography involves measuring the velocity of a shear wave, which is induced by an ultrasound or an external vibration, through the liver. The velocity of the shear wave is then used to calculate liver stiffness. This is a video from EchoSense. It's the company that makes FibroScan to show how this actually works. The transducer has a small piston on its head. The piston is used to tap or flick the side of the patient's body. The flick produces a shear wave which travels through the liver as represented in white. The volume that is sampled is 3 cubic centimeters, which is about 100 times greater than what is sampled by invasive biopsy. The ultrasound probe is able to detect the speed of the shear wave, which is directly related to the stiffness of the liver. And as you'll see here, as the liver becomes more diseased and fibrosed, the velocity of that shear wave increases. The Society of Thoracic Surgery Operative Risk Calculator recognizes cirrhosis and hepatitis, but excludes fatty liver and MASH without cirrhosis. Elevated liver stiffness has been shown in large population studies to predict all-cause mortality. However, its impact on short-term outcomes following a significant physiologic stress is less clear. In a pilot study, our group found that in patients undergoing cardiac surgery, those with an elevated liver stiffness had a postoperative hospital length of stay that was 3 days longer than those without elevated liver stiffness. In that cohort, none of the patients with an elevated liver stiffness had a postoperative length of stay that was less than 6 days. An important risk metric that is calculated by the STS Operative Risk Calculator is a short length of stay, which they define as a postoperative length of stay less than 6 days. So our hypothesis was that an elevated liver stiffness measurement would rule out a short length of stay after isolated CABG surgery. So this was a prospective observational study at a single-center university hospital. The exposure of interest was liver stiffness as assessed by ultrasound elastography, which was obtained prior to the induction of anesthesia. The participants were 164 patients who underwent isolated CABG. All were on cardiopulmonary bypass. Patients were excluded if they were undergoing a non-CABG procedure or had a ventricular assist device. The primary outcome was hospital length of stay less than 6 days, and the secondary outcome was 30-day readmission or death. This table shows the differences in baseline patient characteristics between the groups. History of atrial fibrillation and obstructive sleep apnea were significantly different between the groups. There were also significant differences between baseline hemoglobin and baseline central venous pressure, albeit these were of questionable clinical significance. There were not significant differences with the presence of diabetes or metabolic syndrome. And in addition, the groups did not differ significantly in their MELD score, LFTs, FIB-4 score, baseline creatinine, or reported alcohol use. A total of 164 patients were analyzed. 86% had low to moderate liver stiffness values, and 14% had high liver stiffness. The median overall length of stay was 6 days for the entire cohort. However, those with a low to moderate liver stiffness had a median length of stay of 5 days, and those with a high liver stiffness had a median length of stay of 8 days. Only 13% of the patients with a high liver stiffness had a length of stay that was less than 6 days, where 51% of the patients with a low to moderate liver stiffness had a length of stay of less than 6 days. We performed multivariate logistic regression models using short hospital length of stay, which was less than 6 days, as the dependent variable. Independent variables included a liver stiffness measurement, age, sex, the STS predicted morbidity and mortality, and baseline hemoglobin. After adjusting for all variables, elevated liver stiffness was associated with lower odds of early discharge as compared to low to moderate liver stiffness, with an odds ratio of 0.22. The ROC curve and resulting area under the curve of 0.76 suggests that the final multivariate model provides a good discriminatory performance when predicting early discharge. Our pre-specified secondary outcome was 30-day readmission or death, which was significantly different on a group level, but found to be non-significant in an adjusted multivariate model. Other significant differences that were unadjusted were postoperative infection and blood product utilization, where with postoperative infection, over 25% in the elevated liver stiffness group as compared to 7.5% in the low to moderate stiffness, and blood product utilization 61% in the elevated stiffness and only 35% in the low stiffness groups. We concluded that an elevated preoperative liver stiffness ruled out a short length of stay in 80% of patients, making it a strong negative predictor for early discharge after isolated CABG surgery. This may have implications for improved clinical risk stratification beyond standard scores, and it opens the question as to whether preoperative optimization targeting liver stiffness can improve outcomes. With regards to targeting liver stiffness, it is worth mentioning that although elevated liver stiffness is strongly related to liver fibrosis in MASLD, it can also be confounded by venous congestion that's caused by atrial fibrillation, right and left-sided heart failure, and tricuspid regurgitation. Understanding the underlying driver for elevated liver stiffness is imperative to properly target this marker as an endpoint. However, heart failure and fatty liver disease often coexist, and medications that are indicated for both of these conditions may have the most benefit. This is a Venn diagram showing shared and distinct treatments for both MASLD and heart failure. The incretin mimetics and SGLT2 inhibitors are shared treatments for both entities and may represent the most likely candidates for perioperative optimization. Lastly, the number of patients in our study was small, and it's difficult to make definitive conclusions from small observational studies. This year, a large retrospective study using a multi-center registry evaluated over 1.3 million patients who underwent both non-cardiac and cardiac surgeries. The authors used the FIB-4 score as the exposure of interest and evaluated 30-day mortality as their primary endpoint, and kidney injury, myocardial injury, and pulmonary complications as secondary endpoints. The authors found that an elevated preoperative FIB-4 score dramatically increases the odds of 30-day mortality and that this risk was greatest in younger patients, where the odds of 30-day mortality were as high as 5 times in patients 18 to 49 years of age. Although this study is limited by its retrospective design, it is consistent with the shared hypothesis that silent liver disease confers a significant risk in patients undergoing surgery, and that preoperative optimization strategies for this growing population should be emphasized.